everybody, and welcome to Conversations in Interventional Cardiology. My name is Suzanne Baron. I'm the Deputy Editor of SCAI, as well as the Director of Interventional Cardiology Research at Mass General Hospital. I'm honored to be here today to represent SCAI and SCAI's Editor-in-Chief, Alexandra Lansky. And we're here today to discuss a super important document that was published in SCAI titled Global Results from the Optimized PRO Study, Standardized TAVR Technique and Care Pathway. I am joined by an esteemed panel of SCAI leaders and experts, including Dr. Steve Yakubov from Ohio Health Research Foundation, Dr. Mayra Guerrero from Mayo Clinic, and Dr. John Forrest from Yale School of Medicine. So thank you everybody for joining, and I'm going to turn it over to Dr. Yakubov to start the conversation.
Thank you, Suzanne. I really appreciate that. Thanks for letting me present my study to you, and thanks for publishing it in SCAI. We really appreciated this. Again, this is the global results of the Optimized PRO study, and we're investigating outcomes using the Evolut PRO and PRO Plus device in patients who are undergoing transcatheter valve replacement. We started this study as a optimized pathway to see how quickly we can get patients out of the hospital by doing the same thing, but it morphed into a technique of deployment of the valve, and I'll go through that. So again, this is a post-market prospective multi-center study. It occurred across the world. The United States, Canada, Australia, and Europe all participated, contributed patients to this. The patients had severe symptomatic aortic stenosis. There were an STS score on average was a 3.2, so it's higher than low risk, more in the intermediate risk range. These did not include bicuspid patients, and it didn't include patients who had prior surgical aortic valve or prior transcatheter valve. What we tested was the Evolut PRO or PRO Plus TAVR system using the cusp overlap techniques and what we consider to be an optimized pathway in patients. And we measured all-cause mortality or stroke at 30 days, and then, of course, pacemaker rates and paravalvular leak through 1 year. Our patients were about 80 years old. STS score was over 3. The key procedural outcomes in this analysis were a reconstructed CT angiogram telling us what the ideal cusp overlap technique would be before we get to the lab. The fluoroscopic image of a Lunderquist wire. Again, this is a PRO or PRO Plus device in which the Lunderquist wire was probably much more helpful than current technology. It included a fluoroscopic image demonstrating deployment of the valve about 3 millimeters below the non-coronary cusp, and then rolling over to an LEO view to showing that the valve was adequately deployed below the left cusp. Even with a clearly identified pathway, the cusp overlap technique was followed only ideally about 50% of the time. So not every patient received a Lunderquist wire, or not every image was obtained. The results that we obtained were that the depth of deployment was dependent upon whether all the cusp overlap technique was followed. So in the post TAVR pathway, early discharge was anticipated. It happened with a median discharge day of 2. Non-coronary implant depth was a little over 3, and the median length of stay again was about 2 days. Clinical events were very acceptable. The all-cause mortality was less than 1% at 30 days, and then there was nothing greater than mild paravalvular leak in all of these patients. So our pacemaker rate is dependent upon the depth of implantation in the cusp overlap view. You could see that if the cusp overlap technique was followed, the new pacemaker rate was about 6.4%. Using the Lunderquist wire with an Evolut PRO or PRO Plus did contribute to a lower pacemaker rate. But what was most striking was that the depth on the non-coronary cusp was the single most important predictor of the need for a new pacemaker. So if we attained ultimately a 3 millimeter depth or less, the pacemaker rate was about 6%, and this did not occur at a cost of valve embolization. So in our conclusions, the Optimized PRO study demonstrated that the outcomes are reproducible with the cusp overlap technique across the globe. The cusp overlap technique and the perioperative protocols were associated with very low rates of pacemaker rates and very mild PVL with no moderate or severe PVL noted. And then the best practices resulted in consistent implantation depths and what we think are low complication rates. Thank you.
Well, thank you very much, Dr. Yakubov. That's a great summary of the study that you and your team did. I'm going to throw things to the panel first to just ask the first question. So, either Dr. Guerrero or Dr. Forrest, whichever one of you'd like to jump in, kind of what are your thoughts about what was just presented? And particularly, I'd be interested to hear, we heard about the 30-day outcomes, but do you have any thoughts about kind of from a longer term perspective, 1 or 2 years, how these results may potentially continue out towards a longer term follow-up?
Thank you. Well, I think first of all, congratulations. It's good to optimize, practices, and it's very reassuring to see that if we follow this upgrade in the technique, we can improve the outcomes for pacemaker requirement. Just a comment about how we're moving into a younger patient population, and we're doing younger patients. I think it becomes a lot more relevant. So I think this is very very helpful. I do have a question, but maybe I'll let Dr. Forrest comment first about his take on this, about the implications, and then I have a couple of questions.
Yeah, I mean, I guess, maybe a little background that I will add, and that is that, putting in pacemakers probably makes a little bit of difference, although whether it's putting in pacemakers or the presence simply of conduction system disease that makes a difference, when we looked at a subgroup analysis from the low risk study that's now out to 5 years, we saw that the patients who did the worst of them in terms of pacemakers were patients who came into the procedure already with a pacemaker, because I think having a pacemaker is a sign of underlying, heart disease in general. The next group of patients that did slightly worse was patients who ended up getting a pacemaker, and the patients who did overall the best were patients who neither came in with a pacemaker nor had to leave with a pacemaker. And so, there may be some downside to putting in pacemakers, which studies have shown, which is why I think trying to minimize it is certainly important. Mayra has done a lot of work in understanding, especially in low risk patients, if these valves are going to last 10 or 15 years, I think you have to be cognizant of potential downsides of being too high and understanding sort of your next valve that's in there, regardless of what kind of valve it is. And so I think, that's the other piece that I think goes into this. But what I do think that, Steve, you really to be commended on is that for a long time, there was a lot of sort of uncertainty about the way to do this. And while there still may be cases where you need to adjust things a little bit, really what you have provided, which has been transformational for the practice, is here's how you start. If you start with this, right, we all know that sometimes you have to adjust a little bit, but if you start this way and go from there, you're going to be in good shape. And I think that's really the take home that I came from this, and also how we then subsequently teach people to do the procedure.
It's actually, you brought up a really important point, and something I was kind of trying to get at is right, we know that implanting higher is going to be beneficial for reducing conduction abnormalities, but as you brought up, we're putting these into younger patients. We're thinking about lifetime management. And so, I would be interested to hear, kind of from any of the folks, Steve, Mayra, John, what your guys' thoughts are. Are we going to be in trouble in 15 years when it comes to second valve because we've been placing these super high to avoid pacemakers? Or is this something that we're just all freaking out about, but we don't really need to be? What are your guys' opinions?
Is it really super high? It depends on the anatomy. It may not be super high in most cases. So we're just talking a distance of millimeters, where 2 millimeters can make a big difference in the aortic space, but perhaps not for the coronaries. Also, I'm confident or not confident, how do we say, cautiously optimistic that the technology in the future will be there to help us deal with the leaflets and decrease the risk of coronary obstruction. So I would be more worried about getting the best results now, so that there is a later, we get to come back and work later. I will not compromise, I think, the safety of the procedure now, just thinking that I want to access the coronaries 10% now.
I agree with Mayra. I think that the current valve technology that we have is making coronary access easier. We're going to try to prove that even not as many steps are necessary to cause correct commissural alignment. And I do think that our leaflet modification tools will be greatly enhanced when when the greater number of patients who need TAV and TAV comes along. So I'm a very big fan of trying to do the very best job on the current situation we have now. And I think we're going to have better solutions for TAV and TAV solutions down the road.
And I totally agree. I have one question for Steve, and maybe where we disagree a little bit, and maybe I disagree even a little bit more because we've moved to FX. But I was in the study and I got my hand slapped a few times for not using a Lunderquist wire. And as you put in here, there are some differences that have changed between now that we have an FX system. So maybe I can get just your view. We in our current practice, we definitely try to go with what was outlined here, with the one exception that with the FX now, we're not using the Lunderquist. Do you think with the current technologies we have that you'd still need to keep using a Lunderquist to get these results, or do you think that's been addressed through device iteration?
I think it's been addressed through device iteration. One caveat may be a 34 millimeter valve, which are a little harder to deploy. The larger valves in anyone are a little bit harder to deploy, but that's the only caveat. Larger valves, I would consider a Lunderquist if you anticipate problems.
Thank you. Can I ask a question about the learning curve? Reading your paper, there was a number of sites that had collectively the largest incidence or the greatest incidence of pacemaker requirement. I wonder if was it difficult for those sites to go through the learning curve, or were they like early adapters of the technology? How can we overcome that moving forward?
There's definitely a learning curve. I would say that more than half of the sites weren't using cusp overlap technique, even in the United States, Mayra. I was pretty amazed. And, for many of us who use that cusp overlap technique, I use it in every valve, no matter what it is. I think I forgot how hard it was for me when I first started. I just don't remember anymore. But we saw the learning curve during this study. I especially saw it in OUS patients where they weren't using it at all. And so I'm surprised, but I do think that the cusp overlap technique is being adopted quite readily. Now that people use it routinely, I would expect these pacemaker rates to even fall further, because we saw that in the study. The early experience was worse than the later experience.
Steve, if I can make one comment, I think there have been a few studies that have come out sort of since then that have looked at pacemaker rates where experienced centers are using cusp overlap. One of them is the study that followed this, which was the SMART study that came out. And if you start looking at pacemakers in the SMART study, I think you see what the impact of cusp overlap can actually have in experienced places. So I'd encourage folks to also sort of look at that data to see where are some real world examples of how this changed. And you also see that now when we look at the TVT registry and look at other things for the decreasing incidence of pacemakers with the Evolut system. And I think it's a kudos for you and others who have really taught us all how to do this.
I agree. I think it really has, this is the type of thing that really moves the field forward. And I'm going to turn the topic a little bit to something that's near and dear to my heart, which is going to be what the economics of this are. By implementing some of these very kind of standardized pathways, right, there should be potential savings. You've got lower lengths of stay, you've got lower complication rates like pacemaker implantation, and you are doing it at the cost of, having lots of paravalvular leaks or patients bouncing back to the hospital. So I think that these are other, in addition, from a patient provider standpoint of why this is good to adopt it, it's also good from a hospital system standpoint. So maybe for the folks who are listening out there, are there any tips or tricks you guys would give to hospital systems looking to implement this as far as adopting this kind of standardized protocol? You know, is there specific staff training? Is there specific equipment? Is there increased demands on imaging? That sort of thing. Anything that we should be aware of, because I think this is the example of something that is good from pretty much all stakeholders. How can we get it out there even more?
I'll give you a couple of examples on my end. I don't think this takes a lot for training for standardization adoption. I think it demands that the physicians, the implanters, know how to read a CT adequately and plan appropriately ahead of time, because that cusp overlap angle is probably the most important part of this whole step, and then achieving that in the catheterization lab. There are things that you could do to save costs. If you lower pacemaker rates, you can also decrease the utilization of a pacemaker in the lab. You could pace off the wire. There's cost savings right there. And there's always the growing complication savings by having less access. So then you could just get to single access, your secondary access being the radial, and all of a sudden you've decreased bleeding and you've decreased costs in addition. Those are just a couple of things off the top of my head. John, anything else you'd add, or Mayra?
I guess the one thing that I would add that didn't bring up is that when we need a pacemaker, we don't take the patient out of that room. We do it in the same room, and it backs up our whole day. And so for me, you know, yes, there's a financial benefit to the health system and others, but I think honestly, you know, given the, you know, ways to identify these patients and the volume that we're seeing, one of the biggest benefits is that, you know, we're not holding up the room for a pacemaker to go in and delaying, you know, the 4 or 5 TAVRs that we have scheduled that day, which allows us to get through it, makes the staff happier, makes the patients, you know, that your 4th or 5th patient who's not waiting for their procedure because something else happened. So I think beyond just the savings of the pacemaker, sort of the efficiencies that it's able to do for your team in general and for the flow of the day can't be understated.
And that's going to become even more important, I think, too, when we start, you know, we're thinking about the expanding indications of TAVR, as we're seeing, you know, patients getting treated with, you know, asymptomatic, potentially moderate AS. Our volumes, all of our volumes in all of the centers are going to be increasing. So improving efficiency and patient throughput is going to be important from a patient care perspective. Mayra?
Can I ask a practical question, you know, for me, but and also for the audience? Now with the newer technology, would it be fair to say that maybe just a landing quest for the largest size? I think that you already said that. And the practical question is for the not larger side, is appreciate pica wires that the go-to wire at each of your institutions. Is that what you do?
In my institution, I only use Lunderquist for 34s, but not all the time. And we typically use a pre-shaped wire like the Safari or Confida. We usually use Confida because it's cheaper in our lab, and we've become very accustomed to it. But those are the wires that we use. I would say the Lunderquist use is probably less than 5%, closer to 2% in our lab now.
Yeah, we're similar, Steve. You know, we've used Lunderquist for 34s, and we continue to do it. But for everything else, we use pre-curved wires.
Okay, thank you.
Same for us too. Well, I think this has been a great conversation. I really want to thank our presenter, Dr. Yakubov, as well as my panelists, Dr. Forrest and Dr. Guerrero. Thank you so much for being part of these conversations in interventional cardiology, and hope to see you all again soon. Thank you.